Hello, my name is Sarita Neal, and today I'll be presenting a Parkinson's disease case study. This presentation will explore the symptoms, diagnosis process, and treatment approaches for Parkinson's disease. We'll start with an overview of the condition, then move into a real patient case, discuss the pathophysiology and clinical features, and finish with management strategies and patient education. My goal is to highlight key clinical pearls and show how early recognition and multiple disciplinary care can improve outcomes. Parkinson's disease is a progressive neurodegenerative disorder that primarily affects motor function, but also significant non-motor symptoms. It's the second most common neurodegenerative disease after Alzheimer's and impacts millions globally. Understanding its complexity is essential for healthcare providers to deliver comprehensive care. Parkinson's disease involves the gradual loss of dopamine-producing neurons in the substantia nigrata, which disrupt movement control circuits in the brain. Risk factors include age, genetics, and environmental exposure. About 1% of people over 60 are infected worldwide. Early recognition and management are critical for improving quality of life. Parkinson's disease can begin affecting your smile or handwriting before noticeable tremors start. A progressive disorder where the brain cells die, disrupting movement and daily life. Though challenging, ongoing researches in effective therapy often helping people live full lives with Parkinson's disease. Let's move into our case study, which will illustrate the complexity of Parkinson's disease and the importance of a thorough clinical assessment, which is vital because the progressive nature of the disease requires nurses to continuously monitor evolving motor and non-motor symptoms to adjust care. Also, the assessment provides a complete picture of the patient's physical, mental, social, and emotional state. Helps the nurses recognize when the patient needs other specialties. For the patients receive education about their condition, medication, and self-management, fostering independency and support that can address daily challenges, improving overall well-being and dignity. In essence, clinical assessment bridges the gap between diagnosis and daily living for Parkinson's patients, ensuring care involves with the disease and addresses the whole person, not just their symptoms. Our patient is Bert Frank, a 60-year-old retirement NFL linebacker. He's married and lives with his wife. Over the past year, he's experienced progressive tremors and gait instability. Today, his chief complaint is stiffness in his legs and difficulty maintaining balance, which has worsened over the past 6 months. Bert reports tremors in his right hand, constipation, and a decline in social activities due to his gait issues and imbalances, difficulty sleeping, and has been feeling depressed. He has controlled hypertension. Also, he informs the nurse about a concussion from playing in the NFL years ago. drinks occasionally, and does not use tobacco. And after retiring from the NFL as a linebacker, he gradually had worked as a city bus driver. Parents has no history of Parkinson's disease. Birth Weiss helps him around the house, and he has a supportive family that lives nearby. His vitals show his blood pressure at 100/65, heart rate 52, and a weight loss from 165 to 150 pounds. Physical exam revealed resting tremors in his right hand, bradykinesia, cogwheel rigidity, shuffliness, gait, and a mass facing, all clinical signs of Parkinson's disease. Subjectively, Burt reported tremors, stiffness, fatigue, constipation, smell loss, and sleep issues. Objectively, we see bradykinesia, rigidity, and abnormal gait. Lab tests are normal, and a DET scan confirmed decreased dopamine uptake, meeting the diagnostic criteria for Parkinson's disease. Now let's review the underlying mechanism, pathogenesis, and clinical manifestation of Parkinson's disease. Currently, research is focused on targeting these underlying pathways to develop therapies that can slow or halt the progression of the disease to help the healthcare professionals manage and the patient to live a fulfilled life. And with these researches, there can be more promising and more dignity to everyone. Parkinson's disease is driven by progressive loss of dopaminic neurons in the substantia nigra, reducing dopamine in the striatum and impairing motor control. Lewy bodies of misfolded alpha-synuclein disrupt neuron functions. Neuron inflammation, oxidative stress, and mitochondrial defection accelerate this process. With the combination and clearance mechanism generates an excessive of damaged rate of oxygen, which harm the neurons. Also, an inappropriate immune system involving glial cells or astrocytes become a key driver of the neuronal death. These cells release inflammatory signals which further damage neurons. Clinical manifestations involve motor symptoms including tremors, for example, shaking, often called pill rolling motions in the hands, usually starting on one side and when the limbs is at rest. Rigidity, for example, muscle stiffness, making movement uncomfortable or painful, affecting the limbs, neck, or trunk. Bradykinesia involves the slowness of movement, making simple tasks like buttoning a shirt difficulty and shuffling gait and reduced arm swing. Postural instability was causing impaired balance, leading to falls. Also, there's other non-motor symptoms such as sleep disturbance, excessive daytime sleepiness, or REM sleep behavior disorder. For example, acting out dreams. Depression, anxiety, and cognitive decline often appear early and significant impact quality of life. Also, constipation and sometimes pain such as muscle aches and cramps, and it can affect the olfactory dysfunction, which is loss of sense of smell. Management of Parkinson's diseases require medication management. Management targets both motor and non-motor symptoms, therapy, and a lifestyle adjustment. Advanced treatments, patient and family education, support group services, nutrition, multidisciplinary team or approaches, and overall well-being. First line therapy is carbidopa levodopa to replenish dopamine. MAOB inhibitors and dopamine agonists may be added. Non-drug interventions include physical, occupational, and speech therapy. For refractory cases, deep brain stimulation is an option. Patient education on medicine apprehension, fall prevention, and lifestyle changes is essential. Health on Parkinson's disease focus on understanding it as a progressive brain disorder causing movements such as tremors, stiffness, slowness, and non-movement such as mood, sleep, thinking issues due to dopamine loss, emphasizing that while incurable, symptoms are manageable. Education, educating patients and caregivers about medication schedules and safety measures to prevent fall, nutrition, exercise, mental health, home safety, and support groups can improve the well-being for everyone. Research into neuroprotective therapy and gut microbiome modulation offers hope for the future treatments. Based on what we discussed here I will provide references and discussion questions for the class.